Very good evening and a very good morning to Dr. David Cooper, who has joined us already from USA. Dr. Cooper is a very well-known name in the field of thyroidology. He is one of the co-editors of the iconic textbook Werner and Ingber's The Thyroid. He is a professor of medicine and radiology at the Johns Hopkins University Medical School. He has had numerous accolades from different august bodies, from the American Association of Clinical Endocrinology, from the Endocrine Society, and has also held various important positions in the American Thyroid Association. So, welcome, Dr. David Cooper, and he will talk to us this evening for us on a very important common clinical condition, that's management of hypothyroidism, what the clinician should know. So, over to Dr. Cooper.
Thank you very much. It's great to be here.
You are not yet audible, David.
Okay. Well, sorry. You can't hear me now?
Yeah, that's fine. Yeah, excellent.
Yeah. Yes?
You're audible.
Okay. So good evening to you. Yes, it's morning here in the United States. Can you see my slide? Can you see my slide?
Yes, yes.
Okay, perfect. So yes, I'm going to talk about hypothyroidism. I have no disclosures. This is, for those of you who have not been to Johns Hopkins, this is Johns Hopkins in Baltimore, Maryland. And for those of you who don't know where Baltimore, Maryland is, it's right there. It's right next to Washington. So here is New York, here's Philadelphia, here's Washington, and then this little circle right here is Baltimore. So Baltimore is about 50 miles north of Washington, D.C. So this is what we try to speak about over the next 30 to 40 minutes. Talk really mostly about the treatment of hypothyroidism. I'm going to talk also about T4, T3 combination therapy. I don't know if you have encountered that or have been thinking about that in some of your patients. And then also I'm going to talk about subclinical hypothyroidism, which is really the most common form of hypothyroidism. In other words, very mild hypothyroidism. So what is hypothyroidism? It's obviously just a deficiency of thyroid hormone. Typically, we divide this up into primary, which is the vast majority of all hypothyroidism, where there's something wrong with the thyroid gland, and then secondary, which would also be called central hypothyroidism, which is quite rare. And of course, the most common cause of hypothyroidism all over the world, now that iodine deficiency is no longer all that prevalent in most parts of the world, Hashimoto's thyroiditis for sure is the number one cause. Obviously you could have your thyroid removed or ablated, or there's certain drugs that can cause hypothyroidism. But in terms of primary de novo spontaneous hypothyroidism, Hashimoto's thyroiditis is by far and away the most common cause. So I'm going to focus now on the treatment of hypothyroidism. And obviously the goals of therapy are to reverse the symptoms that are causing hypothyroidism, to prevent the long-term consequences of thyroid hormone deficiency. And mostly those relate to cardiovascular outcomes in terms of dyslipidemia, heart failure, those sorts of things in severe untreated hypothyroidism. But of course, if we overdo it, patients can become iatrogenically hyperthyroid. And in the elderly especially, this can cause atrial fibrillation, bone loss in postmenopausal women, etc. And then, of course, there's always the problem of undertreatment, whether patients are not compliant with their regimen or just not following up regularly. Many patients are also not treated adequately and have persistent hypothyroidism. Now, in the United States, there are a number of options for treating hypothyroidism, of course, the number one preferred way of treating would be levothyroxine. That there are brands, there are generic preparations, any of those would be fine. T3 is being used occasionally in combination with T4. There's really no indication for T3 monotherapy. There used to be a combination pill called Thyrolar that was available in the US. It is not available anymore. And then, of course, there's desiccated thyroid. There are different brands in the United States. This is, desiccated porcine thyroid mostly. And although it has been considered by most experts to be obsolete, many patients actually prefer it because of their perception that this is, open quote, natural, close quote, as opposed to synthetic. And as you probably know, some patients think that being natural might be better. There's no evidence that this is better, of course. And of course, these desiccated thyroid preparations contain both T4 and T3. And so there's a potential for over-treatment. Now, in the United States, levothyroxine persistently is at the very top of the list in terms of prescribed drugs. So this is from, I think, 2022 or 2021. Atorvastatin was number one, levothyroxine was number two, metformin 3, lisinopril 4. I actually did a literature search or just a Google search for the top medicines prescribed in India, and I actually couldn't find it. So I don't know where levothyroxine ranks among the top 20 or 30 prescribed drugs in India. But at least in the US, there were almost 100 million prescriptions written in 2022, representing about 20 million patients with hypothyroidism. And I would say that obviously the number of patients in India with hypothyroidism is probably double that, at least. Okay, so here's our patient with hypothyroidism. You can see she sort of looks hypothyroid, sort of puffy eyes, and has a flat affect. This is her case. She's 70 years old. She's tired. And just on screening by her primary care doctor, was found to have a TSH of 23 and a free T4 of 0.7 or 9.3 picomoles per liter. She really doesn't have any symptoms except for being tired. And I think also this is common in patients who are elderly. Often they do not manifest the symptoms of hypothyroidism the way you might think. So they don't really have any complaints except maybe for fatigue or weight gain or something like that. And this mirrors what we see in elderly people with hyperthyroidism, who also tend to be less symptomatic than younger people. She's got a lot of other problems, steroid-induced osteoporosis from rheumatoid arthritis. She has insulin-requiring diabetes. She has CHF, hypertension, and COPD. So what factors enter into the final thyroxine dose that this patient will require? Because her age and her weight and the severity of her hypothyroidism, comorbid illnesses, other medications, these all really play into the dose of medicine that she ultimately will be on potentially. And so the other question is, should she just be started on her full replacement dose, whatever that might be based on her body weight, or should we start low and go slow and build it up slowly because we are afraid that maybe there'd be some adverse cardiovascular outcome like atrial fibrillation, for example, or myocardial infarction? So let's just take an overview here. The levothyroxine absorption is pretty good. It might be lower in the elderly. Remember, the tablet has to be dissolved in the stomach, so you need gastric acid. So there's decreased absorption in older people with atrophic gastritis, which is not that rare in older people. It also could be affected by proton pump inhibitor therapy. There are liquid preparations that kind of bypass this problem, but one of the ones that we have here in the United States is called Tyrosint. I don't know if you have that available in India, but these are very expensive, and often insurance will not pay for this. Thyroid hormone is absorbed along the small bowel, so patients who have celiac disease or even occult celiac disease may have absorption affected. It has a long half-life, as you know, even longer potentially in the elderly. This allows us to eliminate one dose per day in the week or add another pill. Thyroid hormone doses don't necessarily need to be changed. If somebody needs extra medicine, you could just give them 8 pills a week instead of 7 pills a week because of the very long half-life. Of course, T3 is the major thyroid hormone that regulates or mediates, metabolic function. And T4 really doesn't have any biological activity at all. So T4 has to be converted to T3 in the periphery. There's a little bit of T3 made by the thyroid, only about 20% of the daily production. And so some patients say, oh, my body is not efficient in converting T4 to T3, so maybe I would feel better taking T3 along with T4 therapy. We'll talk about that in a minute. Now, the production rate in most people is around 100 micrograms a day. And given the 60 to 80% absorption in the stomach, that would lead to a dose of 100 to 125 micrograms a day for the average person. Another way of thinking about it is normalization of TSH occurs with that body weight dose. But it's important to remember that that rough calculation is really not particularly accurate. And it really is based more on lean body mass, not on the actual weight of the person. So you can't take a very obese person and just calculate a dose based on their weight. It'll be much too much. So there's a complicated formula for figuring out lean body mass, and you certainly could do that. But anyway, don't think that you should take the whole person's body weight into account in an obese person. Also, elderly people may require less, because even though the body weight may be appropriate in terms of the dosing, they metabolize levothyroxine more slowly than younger people. As I said, the long half-life permits a single daily dose, and even taking 2 or 3 extras a week, for example, or eliminating 1 dose per week. The time of day can be adjusted to improve compliance. You're supposed to get up and take your medicine on an empty stomach at least 30 minutes before you eat, or 60 minutes with water. Some people just like to get up and have their coffee and get going. And if this is an issue, people can take the medicine at bedtime. It's advisable to be fasting. And it turns out that in addition to calcium, iron, other things that can interfere with absorption, coffee, not just espresso, but just regular American, regular coffee can interfere. And there may be even some data suggesting that tea can interfere with the absorption of levothyroxine. If a patient misses a dose for whatever reason, they can always take 2 the next day or take it later in the day. You really need to remind people that would be important to do. And then in people that are really non-compliant, you could even have them take, most of their dose either 2 days a week or even 1 day a week. It's not optimal, but a person could theoretically take all 7 pills that they require for the week on 1 day. There would be obviously, not a constant level of levothyroxine in their blood, but this would be a way of dealing with a patient who had significant compliance issues. So what factors influence the dose of levothyroxine? Obviously, their body weight, I told you about that, the serum TSH. The higher the TSH, the more severe the hypothyroidism, so the higher the dose. But there are other factors that influence this. So one, as we know, is the TSH itself. This is just a study that looks too good to be true, but basically they're just looking at the baseline TSH and the ultimate levothyroxine dose that was required to normalize the TSH, and it's pretty linear, as you might expect. Also, I mentioned that elderly people metabolize the drug more slowly, so the dose to normalize TSH decreases with age. So that's another thing to take into account. But on the other hand, in a counterbalancing way or countervening way, elderly people don't absorb the medicine as well as younger people, maybe due to underlying atrophic gastritis, for example. So even though they metabolize it more slowly, the absorption may not be quite as good as younger people. So that you have to take that into account as a potential fact. And drugs, of course, are major issues when you come to discuss what the dose of medicine should be. I'm not going to read all this to you, but you know that there are drugs that impede absorption. There are drugs that speed up T4 metabolism, like anti-seizure drugs. sertraline, rifampin. There are drugs that increase thyroid binding globulin. The most common is estrogen. So if a person starts taking estrogen or birth control pills, the TBG levels go up, and that will decrease the free T4 levels transiently. In a normal person, you never know that because the thyroid will make a little bit more thyroid hormone to account for that. But in a person on levothyroxine, the dose may need to be increased, and so forth. I'm not going to again read all these. So for drugs that interfere with absorption, they should be separated by at least 4 hours. So the most notorious would be calcium or iron. So if a person is taking those supplements, they really should take their levothyroxine in the morning and maybe take their calcium and iron with lunch or with dinner. On the other hand, if a person is taking an interfering substance and then they stop taking it, then the dose of levothyroxine may need to be cut back because now you're potentially going to cause iatrogenic hyperthyroidism. Also, I don't know about assays in India, but there are certain assay systems that are used in the United States by large commercial laboratories that use biotin and streptavidin in their systems, and people who are taking biotin as a supplement for hair or nail growth, biotin can interfere and cause falsely abnormal thyroid hormone levels. It can cause the TSH to be falsely low and cause the free T4 and T3 levels to be falsely elevated, and it kind of mimics hyperthyroidism. There are other things that also, if they're measured in these systems, can be abnormal because of biotin, PTH, vitamin D, other things that we measure can also be affected by biotin. So if a patient is taking biotin, they should be told to stop taking it for at least 72 hours before they have their blood drawn. So what about the goal TSH? So the goal TSH in general would be between 0.5 and 2.5 to 3 for the average person. But one question that's come up is, should the goal TSH for an elderly person be different? And the reason for that is because of data, not just from the US, but in other countries too, showing that the distribution of TSH shifts to the right as people get older. So these are all normal, healthy people without any evidence of thyroid disease. And you can see that the distribution of TSH in the patients who are 80 years old is shifted this way. And so the 97 percentile of TSH in an 80-year-old, it goes up to 7.5 versus 3.5 or 4 in a 60-year-old. So anyway, this might lead someone to think that maybe the target TSH should be higher in an older person. And I think many of us do believe that that is the case. And in this survey, where American Thyroid Association members were asked, what should the goal TSH be in patients with hypothyroidism treated with levothyroxine, you can see here that people thought up to about 2 for a 60-year-old, between 2 and 4 for a 60 to 85-year-old. And for someone over the age of 85, this was not asked in this survey, but some people might think that a TSH between 4 and 6 might even be appropriate for these patients. So we mentioned earlier, what about the starting dose? Should you just start the patient on their full replacement dose, or should you build it up slowly, the sort of start low, go slow theory? And I think most experts think that for young, healthy people, you can just put them on the full replacement dose. But in older people or people with underlying cardiovascular disease, it's more prudent to start at a dose of 25 to 50 micrograms a day, and then increase the dose slowly on every 6 to 8 weeks based on TSH monitoring. So in patients who are on levothyroxine, who have a low serum TSH on testing, why would this be? And again, just age itself can lead to a decreased levothyroxine requirement. So a person who's been on a certain dose all their lives, let's say they were hypothyroid since they were 20 years old, now they're 65 or 70 years old, that dose may go down just because of their age. Obviously, if the dose is based on body weight, weight loss can lead to a decrease in dose. Other medicines that are now not being taken anymore might lead to a low TSH. And androgen therapy, which isn't that common, but it decreases TBG levels, that might lead to a need to decrease the dose. On the other hand, there are reasons to increase the dose. I would just mention pregnancy as a really important factor here. In normal pregnant women, the thyroid makes more thyroid hormone during pregnancy because the fetus has no thyroid of its own until about 16 weeks of gestation. So we automatically increase the dose of levothyroxine by 2 tablets a week. That's about a 25% increase when a woman finds out she's pregnant, and then monitor TSH monthly, at least for the first and second trimester. Conditions causing malabsorption, drugs that decrease T4 absorption like calcium and iron, as we mentioned, or drugs that increase T4 clearance like anti-seizure medicines, obviously are going to increase the need for thyroid hormone. And then there are drugs that reduce the T4 to T3 conversion, and that would be amiodarone. That's in the pituitary gland. So if the drug is decreasing T4 to T3 conversion in the pituitary, then the TSH will remain high because the pituitary depends on T3 created in the pituitary gland to suppress TSH secretion. So after the person is initiated on thyroid hormone, we're going to repeat the TSH in 6 to 8 weeks. If it's greater than 5, then we would usually increase the dose by 25 micrograms a day. Obviously, in an elderly person, you might decide that 5 micrograms per deciliter would be an okay dose. If the TSH is in the normal reference range, then it's reasonable just to continue it. Although, again, in a younger person, you might want to try to get the TSH a little lower, since most normal, healthy young people have TSH levels that are less than 2.5 or 3. And, if the TSH is below normal, then you would decrease the dose and repeat tests in about 6 weeks. Obviously, in patients with thyroid cancer, we want the TSH to be on the low side or even in the subnormal range. And so if the TSH is less than 0.5, that may be the target that you've selected in a patient with thyroid cancer. Now, we don't do a very good job in normalizing thyroid function in people with hypothyroidism. And this is just a summary slide of 5 studies just looking at the prevalence of high and low serum TSH levels in people, just random people who are taking thyroid hormone. And you can see that many people have low TSHs, many people have high TSHs, and particularly worrisome is in this last study, all of these were patients who were over the age of 65 in this study, and you can see almost 40% of them had a low TSH, indicating over replacement, which can lead to atrial fibrillation and bone loss, potentially. So these are the 2 risks that I mentioned. And this is just one study in people taking levothyroxine, looking at fracture rates. And in this group of people, these are the people who have a suppressed serum TSH. They have a much higher risk of having a fracture over a 5 to 10 year follow-up period. These are patients with thyroid cancer. Now we're looking at the cumulative incidence of atrial fibrillation in the patient with thyroid cancer on suppressive doses of levothyroxine versus the normal population. And again, a much higher risk of atrial fibrillation in patients with thyroid cancer only because they're on suppressive doses of levothyroxine. And I think that one of the things that we have realized is that you don't really need to suppress the TSH aggressively in the vast majority of patients who have relatively low risk thyroid cancer, because the risk of cardiovascular outcomes, negative outcomes, is much higher and unnecessary in many, many cases. Now, I want to just switch to talk about T3 combination therapy with hypothyroidism. Here's a patient who had a total thyroidectomy for a 1.2 centimeter papillary thyroid cancer. And even though she seems to be on the right dose of medicine, she's cold, she's tired, she has this symptom of mental fogginess. And her thyroid function tests are normal. You can see there her TSH is 1.4. And she has read that adding T3 to the T4 may help her. So she wants to know what her T3 is. And so you check her T3, and indeed it is sort of on the low side. And we do see this in patients who've been thyroidectomized on levothyroxine and have normal thyroid function tests. Often the T3 is on the low end of the normal range. So the question is, should combination therapy in this woman be considered? So as you may know, this is something that people are talking a lot about it used to be considered to be anathema that if somebody prescribed this, they were just, sort of out in left field, so to speak, not in the mainstream. But now it's becoming more and more accepted as a reasonable thing to do in symptomatic patients, especially those who've had a total thyroidectomy, who are on levothyroxine monotherapy. And this is just some information from this review article. Levothyroxine monotherapy cannot assure a euthyroid state in all tissues. This is based on animal models where thyroid hormone levels are not necessarily normal, especially T3 levels in all tissues on levothyroxine alone. It's gaining in popularity, although there are many, many studies, randomized controlled studies, that have been difficult to prove. Also, we know that there are certain patients, about 15 to 20% of the population have polymorphisms in various enzymes, especially the deiodinase enzymes, that make the conversion of T4 to T3 less efficient than in the other parts of the population. So it may be that people who have these polymorphisms are the most likely ones to respond to combination therapy. So levothyroxine remains the standard, but it may be that there are selected patients T3 might be a benefit in. And there are guidelines now that suggest that this would be a reasonable thing to do, although, it's not the standard. So how do you do this? There are many studies that sort of try to help you figure this out in terms of complicated formulas. I think the easiest thing to do, if you're going to do this, T3 is about 3 or 4 times as metabolically active as T4. In my patients, if the TSH is normal, I just add T3. I don't cut back on the T4 as 5 micrograms twice a day. But if the TSH is low already on the levothyroxine monotherapy, I substitute 5 micrograms twice a day for 25 micrograms of the T4. So if the person's on 150, let's say of T4, I cut it back to 125 and add T3 5 micrograms twice a day. And then I check thyroid function tests in 6 weeks. If you want to see what the T3 is, you have to measure it 3 to 4 hours after the patient takes the dose, not during the morning, because it has a very short half-life. Now, obviously, there's a risk of iatrogenic T3 thyrotoxicosis, which could cause arrhythmias or decreased bone mass, but this is pretty unusual. There are no long-term clinical trials of this, and I think you probably would not want to do this in the elderly or people with underlying cardiovascular disease. And certainly you wouldn't want to do it in pregnancy or children because, for example, T3 is not taken up by the fetal brain as well as T4 is. So a woman who's on combination therapy, let's say who gets pregnant, you really want to switch her to T4 monotherapy. So we need more studies, especially in patients with thyroid cancer. Why is this happening when people just don't feel quite well? There are no large randomized trials yet. And so the other thing is that many companies now are working on a long-acting T3 preparation. There is no such thing right now. And I can imagine in a few years when something like that does come along, there will be combination pills that will have the right amount of T3, the right amount of T4, and we will be able to give people back the thyroid hormone mix that their own thyroid used to make. Now, I want to talk about subclinical hypothyroidism briefly. So this is mild hypothyroidism. The TSH is usually less than 10. Some experts have divided this up into 2 categories: mild, or grade 1, where the TSH is between 5 and 10, and this is most people, and then more severe, or grade 2, where the TSH is greater than 10. But remember, the free T4 is still normal. Most of these people have positive antibodies. Some people may call subclinical hypothyroidism mild hypothyroidism. And it's pretty common. So if you just screen, the general population, up to 10 or 15% of all people have this. But of course, it's dependent on the reference range for TSH. So what is a normal TSH? Because that's how we define subclinical hypothyroidism. And as I told you, there's a risk of overdiagnosis if you use just the standard reference range that the lab uses in your institution, because there aren't any commercial laboratories now that have age-adjusted reference ranges. So you just have to remember that as people get older, the TSH levels go up. even in normal people. So a TSH of 5 or 6 may be a completely normal TSH in a 75 or 80-year-old person. That is not subclinical hypothyroidism necessarily. So why do we even care about this? These are the issues that maybe there be abnormal cardiovascular function and lipid status. There may be hypothyroid symptoms. There may be altered cognitive function and mood. And also, it may be that patients will progress over time to overt hypothyroidism. Let's just talk about this one. This is the main one that people discuss. And there are a number of large studies and meta-analyses that have looked at this. And this table just summarizes the main studies. And now the outcomes over here are coronary artery events, mortality, heart failure, stroke. These are the references. These are the TSH levels. And in these studies, they've stratified the TSH to be slightly high, up to 9.9 and then above 10. And here's what we see. Every outcome gets worse as the TSH goes up. Although, it's not necessarily that different in this group versus this group, but it's more statistically significant in TSH patients with TSH levels that are greater than 10. But even, with TSH levels between 7 and 9.9, there's a study showing increased cardiovascular, coronary heart disease mortality. On the other hand, there are other studies that suggest that the higher your TSH, the longer you live. So here is a study looking at people over the age of 85 who were just followed, 643 people. And you can see this is the baseline TSH previously, 5 years earlier, and the longer they lived was equated with higher TSH levels. Now you could say, how could this be? How could a person with a TSH of 5 or 6 or 7 or 8 live longer than a person with a normal TSH? And there's no accounting for this. There are data in laboratory animals, for example, in rats. If you make a rat hypothyroid, it lives longer than a normal rat. Now, it may be that's due to decreased metabolism. It may be that rat is sluggish and constipated and cold. But nevertheless, there are some data that suggest that mildly hypothyroid people live longer than normal people. And so another way of thinking about this is that in people who have subclinical hypothyroidism, being old kind of protects you from the negative effects potentially. But in younger people, maybe we'd want to think about treating them. And these are just, the names of several studies that have looked at this in younger people versus older people. And as I said, there are even studies that suggest that the risk of death is lower in people who are in their 80s and 90s who have mild hypothyroidism. Now let's talk about symptoms and other factors. This is a study just looking at symptoms in people that were normal, subclinically hypothyroid, or overtly hypothyroid, just the number of symptoms. And you can see here that most people with subclinical hypothyroidism don't have any more symptoms of hypothyroidism than normal people do. So this is not a condition that causes hypothyroid symptoms in general. On the other hand, I just want to point out, this is going along with the mortality data that I showed you. Now we're looking at walking speed in subclinical hypothyroidism as an index of functional mobility. And you can see here that this is the gait speed. This is a measure of overall health in elderly people. And it looks like the higher your TSH, the faster you walk if you're an elderly person. I'll say that again. The higher your TSH, the faster you walk. So again, in elderly people, there's really very little evidence that being hypothyroid causes symptoms or any kind of adverse effect on the person. So it may be that it's younger people that we should be concerned about. Now, the largest randomized controlled trial of subclinical hypothyroidism was published in the New England Journal of Medicine in 2017. The problem with this study is it was in older people, not younger people. All the people were over the age of 65. Half got levothyroxine, half got placebo. And then after 1 year, there were a number of outcomes, especially symptoms and tiredness scores, quality of life questionnaires. And the mean TSH at baseline was 6.4. In the placebo group, it went down to 5.5. the TSH was 3.6 in the levothyroxine group. And at the end of the day, there was no difference in any outcome. There was absolutely no benefit of treating the subclinical hypothyroidism in these patients. But remember, they were all over the age of 65. There have been a number of subgroup analyses of this study. Here in this study, only people over the age of 80 were looked at. There was no difference. In this study, people with the highest symptom burden were looked at, no difference. And in this study, people with depressive symptoms were looked at, again, no difference. And in this meta-analysis, where this paper was very prominent, looking at symptoms or quality of life, these are other studies, but the one that I just showed you is this big study here with the most number of patients. There was no difference in terms of these outcomes. On the other hand, I just want to point out that this study to you, this is looking at cardiovascular events and cardiovascular mortality. This is not a randomized controlled trial. These are data from the United Kingdom General Practitioners Database. And basically what we have here are heart events or ischemic heart disease events in people aged 40 to 70 who either did or did not get levothyroxine treatment who had subclinical hypothyroidism. And you can see here that there seems to be more events in people that were not treated compared to people that were treated. On the other hand, in people that were over the age of 70 with subclinical hypothyroidism, there was no difference in cardiovascular outcomes in people that were or were not treated. So again, this is not a randomized prospective study, but I think it's intriguing and still opens the door to the possibility that treating a younger person has advantages versus treating an older person. Now, another reason to consider treatment would be progression to overt hypothyroidism. Here's the idea that the person's normal, then their TSH goes up as the T4 and T3 start to go down, and ultimately they become overtly hypothyroid. And this takes some time, but it turns out that some people recover from this and they don't inevitably become hypothyroid. So anyway, we have a crossroads when we have a patient in our office: treat, don't treat. How do we resolve this? And the arguments against treating are that there's no good data, especially in older people, that this is going to be of any benefit, although it may improve mortality and cardiovascular outcomes in younger people. The data on quality of life, mood, cognition are negative almost universally. Also, some patients spontaneously become normal again, especially if their TSH is less than 10. So we would never treat a person unless their TSH was persistently elevated. Very often we get a TSH of 5 or 6 and we repeat it a month or two later and it's normal. And then of course there's the cost and danger of overtreatment. I showed you that study showing that many people actually end up having low TSH on levothyroxine therapy. So here is just a table showing what you might consider. In people under the age of 65, this is the normal reference range, who have very mild subclinical hypothyroidism. You might measure antibodies because if they're positive, that does increase the risk of progression to overt hypothyroidism. In people that are asymptomatic, there's really no indication for treating these people, but you might consider treating people that are symptomatic, who have positive antibodies, whose TSH levels seem to be going up, and certainly anybody who's thinking about getting pregnant, and a person who has an enlarged thyroid, because treatment may decrease the thyroid. But in older people, no treatment. As the TSH starts to creep up, again, you would probably treat these people that are younger and consider treatment in people that are over the age of 65, because there is one or two studies suggesting that there may be a higher risk of cardiovascular mortality in people with TSH levels in this range, even in age 65. And the TSH of 10 or above is a line in the sand that most people agree should be treated, although the target TSH may be different in younger and older people. Now, I just want to close by mentioning one other thing that people don't talk about very much in this context, and that is that the risk of thyroid cancer in people goes up in a given thyroid nodule with their TSH. So this is the risk of malignancy in a thyroid nodule, and these are the TSH levels in all patients and people excluding people taking levothyroxine. And also the staging of thyroid cancer is higher in people with higher TSH levels. So in other words, more advanced disease in people with higher TSH levels. This is a meta-analysis looking at TSH levels and the odds ratio of a nodule being malignant. And you can see again, it goes up as the TSH goes up. And this is another study looking at the risk of thyroid cancer in nodules in people with autoimmune thyroid disease. And again, the higher the anti-TPO antibodies, the risk of thyroid cancer goes up. And in this study, looking at people taking levothyroxine, so here we have negative antibodies in the thyroid nodule, positive antibodies in thyroid nodules, and this is people who have nodular Hashimoto's thyroiditis. And now we're looking at TSH levels here. These are on levothyroxine therapy. Down here are the percent of people who have papillary thyroid cancer in these three categories. And you can see here that in patients with nodular Hashimoto's thyroiditis, with TSH levels that are higher than these groups, there's a higher risk of papillary thyroid cancer in people who have a TSH level that is not suppressed. On the other hand, in these three patient groups, in people that had TSH levels that are less than 0.9, there was no difference in the risk of papillary thyroid cancer. So there's some evidence that treating people who have mildly elevated TSH levels may prevent the development of papillary thyroid cancer. Again, there are no randomized trials to show this, but I'm just pointing that this may be another reason to consider treatment, especially in patients who have nodular Hashimoto's thyroiditis on an ultrasound. So I've added nodules to this indication for treatment of subclinical hypothyroidism. So this is what I've tried to cover in the last 30 to 40 minutes, and I want to thank you very much for your attention. And I think we have some time for questions if you want to.
Thank you, David. That was wonderful coverage of a vast area looking at management of hypothyroidism. We will open the floor and take any questions from the audience, questions or comments, quick ones. Professor Arudash Vishwas is a cardiologist.
You have to transmit the question to him. This is regarding what's the follow-up who are long-term on thyroid replacement, living well. Maybe he was replaced on 40 years, now he's 70 years. What are the issues in him?
Right.
Have euthyroid throughout.
Yeah.
Yeah. So I think that thank you for that question. That was a good question. You know, obviously people who are hypothyroid for the rest of their life. It's not something that goes away. And so they need to be monitored with thyroid function on an annual basis, I would say. And as I mentioned, as people get older, the dose does go down over time. And so that's the reason to continue to monitor. And obviously, some people have issues with adherence to the regimen. So, you know, you want to find out if they're taking their medicine or not. And if their TSH levels are low, then you need to cut back on their dose. But I think the minimum would be annual. I don't think there's any role for doing it more frequently than that, actually.
Right. And you mentioned there are two sort of opposite influences as one ages. One is the TSH level normally tends to creep up a little bit. On the other hand, the T4 absorption also tends to get less. So what has been your experience in terms of those requirements, those who have been treated maybe from age 25, 30 till 75? So does the dose requirement come down?
Yes, but not until the patient becomes, you know, I'm old now. I'm over 70 myself. So I don't want to analyze the TSH across the age span. It goes down as people get older. And to be, you know, not to be personal here, but I take levothyroxine myself, and the dose that I've been on it for 50 years, and my dose has decreased over time.
You said decreased?
Decreased, yes.
Right, yeah. Okay, so are there any other questions? Yes, Professor Udash, who is physician and internist and rheumatologist.
How frequently you should follow up or monitor, particularly in pregnant patient, and how it differs from the non-pregnant female, and also the patient above 70 with ischemic heart disease?
So that's a good question about pregnancy. In as I mentioned, in pregnant women, as soon as the woman finds out that she's pregnant, we advise them to increase their dose of levothyroxine. And one easy way of doing this is to tell the patient just to take 2 extra pills per week. That's about a 20 to 30% increase. And to get a TSH, when she finds out she's pregnant, increase her dose, and then get another TSH in 4 weeks. And we have, through our electronic medical record that we have, we can communicate with people pretty easily about this. And then we monitor the TSH monthly, at least during the first 20 or 25 weeks of pregnancy. After that, the levels of thyroid hormone or the dose requirements don't change during pregnancy. So it kind of goes up in the first and second trimester, and then it plateaus and doesn't change. And then when the baby's born, the dose goes back to the original pre-pregnancy dose. And we tell the patient to be sure to do that. As I mentioned, in non-pregnant women and elderly people, I think checking thyroid function tests on an annual basis is all that needs to be done.
So what we're specifically asking is an elderly, let's not say elderly, above 70 was his stated age, who has got ischemic heart disease. So would you have a different routine to follow up?
No, I mean, once the TSH is normal, then I don't think you need to follow any more carefully. I mean, as I said, in people who have ischemic heart disease or elderly people, the target TSH may be higher than in a normal, younger, healthy person. So let's say a 75-year-old person with coronary artery disease, the target TSH could be 4 or 5 even in a person like that. There's just no evidence that normalizing the TSH would be of any benefit to that person. And as I showed you, there's even data to show that a high TSH is associated with a longer lifespan than a normal TSH in elderly people. So there's no reason to be aggressive with levothyroxine dosing in older individuals.
Right. So if there are no other questions or comments, then we will once again thank David very profusely. Thanks for joining us.
Thank you very much.
Yeah, that's wonderful. Thank you very much.
Have a good rest of your evening. Bye.
Thank you.
Bye-bye. Thank you.
We'll wind this session.
Recording stopped.